Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you today as I highlight an important paper from the October 2024 edition of the Journal of Rheumatology. Today, I will be speaking with Doctors Lauren King and Gillian Hawker, who are the first and senior authors, respectively, on our featured article titled "Glad to be Walking Better: Change in Self-Reported Difficulty Walking After Exercise Therapy and Education in Persons with Knee Osteoarthritis." I want to thank you both for taking the time to speak to me and to our listeners on behalf of the authors of your paper, and looking forward to this discussion. So with that, we'll start. So could you please explain, for those who may not be aware of what GLAD, spelled G-L-A, /D, is, and what's the purpose?
Yeah, so first of all, thank you, Earl, just on behalf of our whole co-author team. Thanks for selecting our article, and it's just a pleasure to be here and have this discussion. So yeah, to your question about GLAD, what is it? So GLAD stands for the Good Life in Osteoarthritis in Denmark. So Good Life with Osteoarthritis in Denmark. And it's an education and exercise group-based program led by trained therapists for people with hip and knee osteoarthritis. And it's a program that's about 8 weeks long. So it encompasses a couple of 3 education sessions and then 12 exercise sessions that are done in a group. And the exercise sessions tend to be done over 6 weeks. And this is a program that was started in Denmark in 2013 by 2 of our co-authors and international colleagues, Drs. Søren Skou and Roos. And since then, not only has it been rolled out throughout Denmark, it's been rolled out internationally. And what's another component, what's really neat about GLAD is it's also a registry. So with all the participants that go through the program, data is collected before they start the program, when they complete the program around 3 months, and then also at a year. So it really provides data, ripe for study.
Great. Sounds like a great program, and we'll hear about it. So could you just outline who was studied, what was studied, the outcomes, and over what time period? So really the methodology.
Okay, so this was a cohort study. So we looked at individuals with knee osteoarthritis who were enrolled in the GLAD program in Denmark between mid-2018 and mid-2020. And we selected to study a period really where there were the variables available in the data set that we were interested in, because different variables get collected at different time points. And so that really guided the time point that we selected. In terms of the participants, so the average participant in our study was an individual with knee osteoarthritis. They all had knee osteoarthritis, but the average participant was 66 years old, had moderate OA pain intensity. So the average pain intensity was 46 out of 100 on the 0 to 100 visual analog scale, with 100 being the worst. And about 2/3 of our participants were women, and that's really in keeping with what we know about osteoarthritis, where women are affected more than men. And then you were asking about the outcome of our study. What were we studying? And our outcome, our primary outcome, was self-reported walking difficulty. And being able to walk is such a fundamental capacity that people value. When you can't walk, there's loss of independence. It becomes much more difficult to manage everything else going on in your life, your daily activities, managing the rest of your health. Risk of health complications goes up when you can't walk adequately. And so we felt that this was an outcome that was highly relevant to people living with osteoarthritis and also to society. And to assess this outcome, participants had answered a question, just a brief question to report really their ability to walk. And they had 5 options, from having notes saying, I don't have any difficulty walking, or no difficulty, or no problems walking, about slight problems walking, about moderate, severe, and then unable to walk.
Okay. Well, now that we know what you did, what did you find?
Yeah, so the of our sample, so one of the key findings really was that a lot of people who enter GLAD have difficulty walking. And so we think about how prevalent osteoarthritis is. And of the people entering the program here, 41% had difficulty walking. The really neat finding was that about half of the individuals who reported moderate to severe difficulty walking, so difficulty walking was having a big impact on their lives, about half of them said after completing the program reported that they had no difficulty walking or only slight difficulty walking. And so we felt that was a substantial improvement. And then what more, at the 12-month period, that improvement was maintained. And so that was also a really important finding to see that this wasn't something that then, you might go back and see regression. Actually, people remained improved. We were trying to look at in a bit more detail the individuals who reported moderate to severe difficulty walking. So we had about 5,000 people in our sample. Around 2,000 were those that reported moderate to severe difficulty walking. We wanted to understand what the key factors that might increase or decrease the likelihood of having this improvement in walking difficulty after completing GLAD. And we did this because we wanted to be able to flag people who might need extra support to be able to meet their walking goals. So we found just overall, or just maybe in more of a summary, people who were older, had a higher body mass index, had more severe symptoms, were those who were less likely to improve. And this may make sense because, maybe we shouldn't expect GLAD to be a one-size-fits-all approach. And there may be individuals who may progress more slowly, may need added sessions, may need added support, may need additional therapies to help manage their OA to see the improvement in their walking.
For their walking difficulty, their walking difficulty may be also being contributed by other clinical conditions as they get older. So they may have diabetes-related numbness. They might have had a neurologic event. They may have shortness of breath. So, there's lots of reasons that people who have a higher BMI and are older might be less likely to improve in their walking. But overall, it's a good thing.
Were along those lines, were you able to measure? I'm sorry. Did the database include comorbidities? It's such an important issue, not only in people who are older, but in everybody, for exactly the point that Dr. Hawker said. And if you couldn't, I understand that it may not have been a primary thing, outcome that was collected, but or not. Were you able to look? Is the data there? I know, as I could see, it wasn't in the paper, but I was just curious.
Yeah, so there are some data on comorbidity in GLAD, and what we had used, or we had presented in our table 1 and included in our regression analyses, was number of comorbidities, rather than look for the effect of a specific comorbidity or try to highlight or hypothesize some that might be associated with our outcome. We kind of said, well, how does the burden of comorbidity affect someone with someone who's managing multiple chronic conditions may have they make it more challenging. And so when we look at number or burden of comorbidity, we didn't see an effect on our outcome. But you're right, that's different than looking at specifically individuals with cardiovascular disease or neurological disease, as Gillian points out.
Yeah, I know it's hard, and you're limited by the power of your cohort. You'd need huge cohorts if you're dissecting.
But I will make a plug for another paper that we've had published around comorbidities and response to OA treatment. We have shown that that comorbidities don't limit somebody's response. You may start from a lower or more your starting point in terms of your symptoms, but your improvement is just the same as those who have no or fewer comorbidities. And so I think there's some important messaging there. You still have the capacity to improve even when you have other things going on with your health.
And I just wouldn't mind adding that the whole reason we were looking at walking difficulty is that we had hypothesized several years ago, and Lauren had done some nice work, really nice work with members of our team, showing that the number one cause of difficulty walking in the population is hip and knee OA. And what she looked at with the group is a whole bunch of other comorbid conditions, including neurological problems, all the things I was just mentioning. And OA comes out still on top. And that walking difficulty we subsequently also showed was related to your likelihood of experiencing a cardiac event, all-cause mortality, diabetes incidence, and in people with diabetes, complications of diabetes. So we have always felt that walking is a proxy. It's an indicator of somebody who's less able to be mobile. And by being less able to be mobile, maybe they can't follow physical activity recommendations. Maybe they just can't be physically active. They definitely are more likely to get to end up unable to work or unable to live alone. And in fact, we've seen that the number one reason now for going to have a joint replacement has shifted from pain still up there. Difficulty walking has now come across and past pain. So there's a lot of reasons to care about walking. And so showing in a mixed bag of people with osteoarthritis who have lots of other conditions going on, that going through GLAD can improve walking is really important from a population health perspective, at least in our opinion.
I agree 100%. I think walking is crucial to feeling good about yourself. I mean, being immobile, you can't really function well,
No.
So I think it's great findings, and it is encouraging that people with multiple comorbidities still could improve. And I think that that's really important and hopeful. So I think
And
we just,
yeah. Sorry, Lauren and I actually met with some individuals from Ontario Health earlier this week or last week. I can't remember which week it is. And GLAD is already incorporated as a treatment option for people that are seen in the arthroplasty, joint replacement triage clinics. But our point is, and was made to these individuals, that this could potentially prevent the need for a joint replacement, and that we should be able to access GLAD or programs like GLAD, but GLAD is out there. It's just not covered. It's not funded by the government. So it's evidence like this that we're hoping will shift the way the government thinks to provide access to mobility-focused interventions for people with arthritis, not just the time when they're going to see surgery.
I think so, but that's problem with all health payers, not only our provincial government. I'm sure it's payers everywhere. Reluctant to do things like
that. So GLAD is publicly funded across Denmark, I believe Sweden as well. So there are models for it to be really just widely implemented and accessible. And I think we need to see that change in Canada and hopefully other countries as well.
Yeah.
Excellent. I think we discussed the subgroup analysis. Anything else you want to discuss about that, of different other subgroup analyses you did?
We did, for just a descriptive of, how do people rate their or report their difficulty walking before 3 months, 12 months. And from those descriptives, we did break down into 3 groups and did stratified analysis by age. So under 65, above 65, by sex, and by pain severity. And overall, the results were really similar, showing, and again, this is the 5,000 people enrolled, not just those who were severe at baseline, but that really the effects of GLAD appear to be similar overall.
That's again showing the robustness really of this, which is very encouraging. Tell our government, tell funders, and including our government.
We have. And in fact, GLAD as a virtual, so online version, has also been developed and assessed in a randomized trial and shown to be similarly effective. So, you know, we do have access to that as well, but for a fee at this point.
Great. And so we've talked about what you found. Where's it going? Where does the future, what should we do with these findings, which are excellent? What future studies should be done? Or are you doing, if you don't mind that, or my asking?
Well, GLAD was developed by our colleagues to really bridge this gap between what our guidelines suggest and what's happening in clinical practice. And it was really to put into practice what we know, what's the care that people with osteoarthritis should be receiving. And I think with that in mind, that's where we have to go next, right, is to get it into practice. And they've done a good job of that in Denmark, like I just mentioned. But how do we do that in Canada, and how do we do that in other countries around the world where we know the burden of OA worldwide is so large, and so it's that implementation work that's really needed. There's now been a number of studies to look at the improvement or response across a number of outcomes, and now we've added to this with looking at the outcome of walking difficulty. But so now we're at the point where this really needs to get into practice.
Right. And I think, just coming back for a minute, I think the robust that it lasted, so long after the intervention. And I think that's just so encouraging. For most interventions, or frequently interventions end at a point, but this was very encouraging.
Well, actually, on that note, Earl, I think one of the things that we often fail to do when we're doing behavioral modification of any kind, which is super hard to do, is to talk clearly and listen to our patients so that we understand what they really want to accomplish. And if people are given the skills through the GLAD program, the ability to actually figure out how to do what they want to do, develop the strength, develop the balance, whatever it is to do it, they're motivated to do that thing because they've already said, this is what I want to be able to do. Which is very different than sending somebody for instance, quadriceps strengthening exercises, which is not a goal for most people. They might want to do something that would benefit from it. But I think it's just, we have to change the way we think about what motivates people to change behavior. And that's also work that we've been implementing into our implementation science work going forward.
And I think to piggyback on that, when we talk about behavior, we have to talk about clinician behavior too, because of the widespread apathy around OA. But once you have a publicly funded and available program to treat people's OA symptoms, then the referrals will happen because there's a solution, there's something accessible. It's really hard to, aggressively screen for and treat something when you don't have a solution, when our first line measures aren't covered. And so I think the widespread implementation may also change clinicians' behaviors towards OA. And so I'm really hopeful about that.
Yeah, that leads beautifully into my next question. I was speaking with an American colleague who is our OA editor and had mentioned, this was a few years ago, that GLAD is not in the US. And having read about it, I was surprised. So do you know which countries do and don't have therapists? I understand therapists have to would have to undergo a training program. And, would you know of any barriers that would prevent what appears to be an effective program from being universal, aside from cost, being universally implemented or having the option to get it?
Yeah, so in terms of the countries, it's an expanding list. At some point, the US had a pilot project going. I'm not sure where that and what that amounted to, but from across Europe to Canada to Australia, New Zealand, China, there's an expanding list of countries that offer GLAD. I think you're right. So the individuals who lead the GLAD the therapists who lead the sessions have to undergo 2 days of training. And so that to be able to call yourself, you know, you're offering a GLAD program, that's kind of a necessary step. And so that might be a barrier. But it seems like there has been encouraging progress and spread throughout the world.
Yeah, and there are many other programs that have been developed that are similar to GLAD. Australia has developed sort of its own version. They also have GLAD. But really, money and awareness are the two barriers. I guess it's big business to go to a sports therapist, or, you know, there's a lot of corner store opportunities for people who have capacity to pay. And so there is obviously sometimes a conflict of interest. But I think back to what Lauren said a minute ago, a lot of health professionals just don't believe that these things work, and they don't know how to get their patients there because of the cost barrier, insurance barrier. So they've, again, in qualitative work that Lauren's done for her PhD thesis, she's clearly shown that clinicians, if they had a place to refer these people, would refer them. It's they don't know what to do. So what they do is they hold on to their patients until they need surgery, or they think they need surgery, as opposed to giving them all the opportunities for therapy before they need surgery.
Well, hopefully the world will listen to this interview and read your article.
Sure hope so.
On that note, is anything you want to add that we might have missed?
No, you can do your best too as a journal to spread the word to readers and the arthritis community. Again, it really is at this point about changing policy and practice. These are not, it's not new that exercise works for OA.
Well, we are doing our best. We're public and with an editorial. So
excellent. Excellent. Thank you, Earl.
Well, thank you. And I want to thank you both for having an excellent discussion. And as a pediatric rheumatologist, an enlightening thing, but I had heard about GLAD, as Dr. King would know. And I want to thank both of you for taking the time to review your findings and have an excellent discussion. And to our viewers and listeners, please read the complete paper, GLAD to be Walking Better, Change in Self-Reported Difficulty Walking After Exercise Therapy and Education in Persons with Knee Osteoarthritis. And there is an accompanying editorial, Evidence that Good Life with Osteoarthritis in Denmark, or GLAD, an exercise and education program is beneficial for osteoarthritis. Well, that sort of says it all by the editorialists, who are Drs. Grace Ho and Jeffrey Dribbin from Baylor College of Medicine, Houston, USA, and the University of Massachusetts Chan Medical School, Worcester, USA. Both of these are available at our website at jroom.org and in the October print edition of the journal. I want to thank you for joining us and hope you will join again next month when I pick another article and interview the authors from this November 2024 edition of the journal. And I'd love to hear comments on X at jroom or by email, manuscripts@jroom.com. Thank you all.
Thanks to you and the journal.
Thank you.